Thank you, Dr. Streeter. So we're wrapping up a little bit early, of course, since given the absence of our other speaker, but I wanted to certainly open it up to questions for our panelists. Great.
Dr. Peacock, you mentioned the point of care things that you're advocating for, the testing you're advocating for, that there are people that have agendas that would want to hold that up. What could be? What's going on there?
So the lab folks are the people who are in charge of testing, and it is a administrative challenge for them to take these tests that they're responsible for and put them in different environments. And so regulatorily, it's a problem. There's a CLIA, which is the body that certifies labs, that makes them responsible for every test that's done anywhere within a system. And so the more those tests are farmed out into point-of-care environments, the bigger of a management problem it is. And they don't have the staff to do that commonly. And so they then will resist the implementation of point of care because of just the hoops they have to jump through, and they're all concerned they're going to lose their license if they don't manage it correctly. These are all legitimate concerns on their part. The trouble is that you have this conflict between the clinician who needs the answer now and the lab guy who's responsible for the test that's not done in their environment. So until that is somehow more satisfactorily worked out for both parties, it's going to be some resistance. There's significant resistance. There are hospitals that do no point-of-care testing whatsoever. It sounds absurd, but it's the way it is.
So with the insurance and Medicare reimbursement and whatnot, is there any difference in that for the point-of-care testing versus if it's sent to the lab? Is the reimbursement the same, or are there provisions that cover the point-of-care, or is it only the lab currently?
So in the DRG world, the way you get paid is by diagnosis. So, and I'll use heart failure as an example. So you come in with heart failure, you get admitted to the hospital gets $4,500. That's it. If you burn it up doing point-of-care testing or unnecessary x-rays or some other crazy tests, you just go broke. So whereas point-of-care does have an expense tagged to it, and the reason it has an expense is because this management issue that the CLIA regulations require that the lab people watch this, so it's more labor intensive. It's one test at a time, tends to be, whereas the machine that you saw earlier, they can do 10,000 tests in a, just through these crazy high output machines. So there are true costs associated with it. And the question then becomes, you have to weigh, is the clinical benefit or the operational benefit justify the change in cost? When it comes to heart failure, the average hospital in the United States loses money on a heart failure diagnosis. They're not at all excited about anything, even if it is better care or better operationally. Nobody's excited about anything that's going to increase the cost of heart failure because they're losing money on it already. Some of that is the way the reimbursement pattern works, and some of it is that you have to have a bigger picture view. But both of those things combine to thwart the implementation in a global sense across the United States of point of care in the emergency department.
And I would just add, as a general matter, diagnostic tests are reimbursed based on the clinical lab fee schedule, and if a test is approved by Medicare for reimbursement, it will be reimbursed regardless of what setting it's performed in. But then again, there's many other issues that Dr. Peacock's alluding to in terms of the utility of those tests and how they're actually used.
So what I'm speaking to is the hospitalized patient. And in most emergency departments, that's about 35% of the patients. 75, or 65 or 75% are going home. That reimbursement structure is completely different than it is for the hospital. And then, as Andy talked about, there's the outpatient world, which is a whole different, that's more of a per test ordered type of deal than it is in the inpatient world or in the ER.
Yeah.
There is a national study which showed that transgendered Americans experience serious amounts of discrimination and mistreatment in emergency rooms. I was wondering if you thought that some of these same issues might crop up in point of care, or if the fast pace of point of care might, in essence, render not enough time for this sort of discrimination and mishandling.
So I'm not aware of your study. So the question I would want to know is what that discrimination was. Did they fail to access? One of the ways that commonly happens in patients who are seen in the emergency department and then discharged for follow-up, and that's where the rub comes. The ER itself is required by the Congressional Omnibus Reconciliation Act of 1985 to see everybody regardless of their ability to pay. So we see everybody. It's a $50,000 personal fine to me. I ain't going to do that. I see everybody. I don't care who, what, where, anything. I'm just going to see you. The trouble is at discharge. So you come in, you got high blood pressure. High blood pressure is not an emergency. I don't care how big the number it is. If you're asymptomatic, it's not an emergency. Go see your doctor. That's where it happens, is go see your doctor. They don't have a doctor, and they can't find a doctor, and they don't have insurance. They aren't going to get a doctor. And now what do we do? So that piece is tremendously problematic about the way we deliver care in the United States, is that when patients leave the acute care, in the acute care environment, we're all going to take care of them. Nobody's going to take on a personal $50,000 fine. When you leave the acute care environment, if you're not plugged in, you are bare naked out there by yourself. And that's where the discrimination, at least how I would perceive it to be. And point of care will have no impact on that because you've left the acute care environment.
So as the payment system is sort of changing, hospitals are moving more towards pay for performance, and part of it might be reducing hospitalizations, so they got to meet certain benchmarks. Is that going to increase the use of POC tests to get the diagnosis and reduce rehospitalization there?
Yeah, so I'm a little bit nervous as a physician about what's going to happen with pay for performance. I don't think anybody really knows. And I'm as much involved. I was the president of the Society of Chest Pain Centers last year, and so I was tremendously involved in the value-based purchasing and how this is all going to work. And I'm having trouble predicting how this is going to happen. In the perfect world, it'd be exactly like you said. Hospitals would be motivated to do point of care because it gets patients out, it identifies them quicker and gets them out quicker and treats the ones that need to be quicker, and quicker is better. But it's not all going to be based on quicker. It's also going to be based on, we're taking on real costs here. And if you're losing, and here's my big fear about value-based purchasing and pay for performance, is that the hospitals that are least able to take an economic hit are going to take one. And the urban areas, the underserved, and my world is, all emergency docs give away a lot of free care because of where we practice. We understand this. We are the safety net. And my big concern is we're going to frazzle the safety net, and we're going to have all sorts of people falling through the cracks because the hospital that serves LA County is hanging on by its teeth right now. And with value-based performance reimbursement, they could take a 2% hit on their money and die. So it's going to be a little bit scary when that kicks in, and because I don't think anybody really knows how it's going to happen to the safety net hospitals. Bad answer, I know.